introduce you to our panel. So first,
Rock style, star style. There you go.
oh great.
Yes, please.
My biggest complaint is that people cannot hear me, so I'll have to really remember to put this up to my mouth. Okay. All right. So first we have Chris Miller.
Of course you would.
Well, you sat right here, so she's been a midwife for over 40 years and has delivered thousands of babies. So, do you have a ticker? Do you have an exact number?
I quit counting after 100, I think. That was good.
That's good. That's awesome. Okay, and Pam Udy. Pam is a wife, mother of 5, a birth activist, a mentor, writer, and speaker. Pam has 12 years of experience as a member of the board of directors, including a term as president of the International Cesarean Awareness Network, or ICANN. Pam has had 2 cesareans, followed by 3 vaginal births. She supports, educates, and encourages moms who are seeking to avoid a cesarean, those recovering from a cesarean, those who are looking to have a vaginal birth after cesarean, which is a VBAC, and those seeking for healing after any traumatic birth. She now has her own business called Circles of Time, where she empowers women to know their rights, to engage, to take action, and become a change agent in their families to positively affect generations. And Jessica Roberts. She is a follower of Christ, a wife, and a mother of 5 boys. She became very passionate about pregnancy, labor, and birth after her own journey to fight for the birth she desired. She is now a doula and loves helping women make informed decisions along their journeys into motherhood. Jessica. And Dr. Kristine Zelenkov. She graduated from medical school in Utah and then trained in New York City, where they did the original studies on VBAC safety. She practiced in Seattle for 16 years, then moved to northern Utah in 2001, and loved practicing out of Davis, Ogden Regional Medical Center, and McKay D Hospital for 13 years. She is now semi-retired to take care of her husband and will continue to support advocacy for women. She has been a friend to Penny Simkin and Chris Miller, and is currently volunteering on the subcommittee for safety in out-of-hospital births. This is our panel. Yay! Yay! So I'm going to sit down now. All right, so let's start with Jessica. We want to hear a little bit about how you got involved in the movie and what this experience was like for you.
Okay. Do I hold it? Did you turn it on?
This one or
Turn it on.
here we go.
I'm going to clip it so I don't have to hold it. Oh, can you hear me?
Can you hear me now?
Sorry. I was a part of a VBAC group online. It was a forum on Cafe Mom. And the woman who ran the page posted this VBAC giveaway. It was a 100,000 VBAC giveaway. They were interviewing women, and they were going to give each woman $1,000, and they were going to choose however many they wanted for the film. And I called, and I interviewed with him over the phone, and then he called me again and had me come in, and it started really fast. The first time I went, we interviewed, and it was rapid fast. And it was really amazing being involved in the film. I don't think I realized my cesareans were good experiences. I didn't walk away from them scarred. They weren't traumatic. And I don't think I realized how difficult the healing was until I started to want a different birth. And until I realized that they weren't necessary. And then it felt completely different. It felt like I was a victim. I mean, you know, I felt like I had been taken advantage of, and it could have been so different. And so there was a lot of healing through the interviewing that I did with these men. I became really close to them. They provided free chiropractic care and massage and acupuncture. It was amazing. The experience of the film was really, really what opened my eyes to, I don't know, I guess that women can have pain and emotion and disappointment and sadness over their cesareans. So.
Thank you. Thanks for sharing that. Okay, Chris, I'm going to ask you a question. What are some steps a couple can take to avoid an unnecessary cesarean in the first place?
Well, I think everybody that we talk to, as far as, you know, it'd be mothers that maybe the first time around or second or third time around, maybe like Jessica, you know, they've had a couple of C-sections and they don't want another one. Nobody really wants to have another one unless it's necessary. So I think educating yourself, talking to different people, reading a lot, all the different literature, advocating, really. I mean, talking to people that have done it. There's so many out there now, so much information about good VBACs and the people that help you to get to that place. I think that education is probably the most important thing, and always knowing that you do have a choice and you're never forced into a situation that you don't want.
Thank you. Pam, can you tell us some of the risks of a repeat C-section versus the risks of a repeat VBAC? Or did I say that right? Yeah, of attempting a VBAC. So there are risks with repeat cesarean as well. Trying to say.
Okay, can you hear me? ICANN has put out this brochure. It's called After a Cesarean, and I think I have enough copies for everybody. But it does go through making the choice of a repeat cesarean versus a VBAC, and what the studies say about what the risks are. So different risks increase with the number of cesareans that you have. So for your first cesarean, you have a risk of hysterectomy, the risk of blood transfusion, and the risk of placenta accreta. Second cesarean, you have an increased risk of hysterectomy, blood transfusion, placenta accreta, major complications, and dense adhesions. So major complications include one or more of the following: uterine rupture, hysterectomy, additional surgery due to hemorrhage, injury to the bladder or bowel, and excessive blood loss. It's really interesting to me that some doctors will say that cesareans, they know that cesareans cause more blood loss, but they feel like they can control it, so it's all okay, because they know it and they expect it to happen. And with the VBAC, that expectation isn't there, and so they don't feel like they're in control of it. Not that they're in control of it during the surgery, they just feel like they're more in control of it. So, yes, your VBAC, your risk for all of those complications go down. You do have the risk of uterine rupture. What's interesting to me about that is the risk of uterine rupture is there from the time that you have that first cesarean. So during your second pregnancy, the risk of uterine rupture is there whether you're in labor or not. It's there throughout the whole pregnancy. It doesn't matter how you deliver your baby, your risk, you still have the risk of uterine rupture. And it may increase some while you're in labor, but the risk is there throughout the whole pregnancy. So if they really, really wanted to keep uterine rupture from happening, they wouldn't do the cesarean in the first place. But that's not how they see it. They see it as, oh, you've had a cesarean, oh, well, now we can't do VBAC because of the risk of rupture. And it's putting the cart before the horse there. So those are what some of the risks are.
I just wanted to say something. The women that have come and talked to me, about having a VBAC. I've helped, and I'm not saying this, I'm not the one that's done it. The women come to me and they ask me, they know what their bodies can do. And so the most C-sections that one of the mothers had was 5. I've done VBACs for women that have had 3. That's been common, but I thought it was really unusual. One of the doctors said, wow, you're really brave. No, I'm not. The mother was. I supported her.
Awesome, thank you. Okay, so Dr. Zelenkov, from a medical perspective, why are VBACs discouraged and in some places prohibited?
Well, essentially, the whole issue is that vaginal births after cesarean section, if they're successful, are definitely easier for the mother, but there is a higher risk to the baby with a VBAC because of the risk of uterine rupture. Now, if you don't have a uterine rupture, then the risk of the baby to the baby is essentially the same as if you were having a repeat C-section or if you were having a vaginal birth. But the minute the uterus ruptures, then the baby's at higher risk. Now, so the question always arises, what's your risk of uterine rupture? And this is where, you know, it starts to get very hazy. Doctors don't talk to you about the real numbers. If you look at, if you've had 1 previous C-section, your risk of uterine rupture is essentially somewhere between 1 in 1,000 and 1 in 2,000. That's the number. And there are additional numbers that have shown, additional studies that have looked at women with previous 1, 2 C-sections, 3 C-sections, 4 C-sections. And even if you double the risk, your risk is still 1 in 500 of uterine rupture. And so, like anything in medicine, it's either not going to happen to you at all, or it's going to happen to you. And so it's really tantamount that you sit down and talk with the doc and find somebody who is going to give you real numbers, both the statistics in the literature as well as their real numbers. In other words, a doctor may say that you want a VBAC, and he's going to give you a VBAC, but the minute you come in labor, he's going to say, well, you need to have a C-section. And so the real issue is that when you're talking about hospitals, it's all about risk. Okay, hospitals are about risk management. They don't want anything bad to happen to you, which is good, but at the same time, they don't really take responsibility for how they manage you in labor. In other words, like the woman who was in the movie who got to 8 centimeters, well, why did she go backwards? There was something else going on there that they needed to try to figure out because it happened after the epidural. And so, in other words, when you are chosen to, when you choose to go to the hospital has protocols, and they don't really look at you as an individual, and they don't try to figure out why you've arrested. They just have protocols that say at a certain point you have to have a C-section. And so you need to have doctors and midwives who actually sit down and try to figure out what's going on with you. Does your pelvis allow you to have a vaginal birth? And you need to have somebody who's very honest about it, not somebody who's doing it because they just don't want to do it. And so, you know, that's the hard thing, is that you have to find somebody who supports you in doing it. And that's why when you choose to have a home birth, it's not the safest place to have it, because then if you have that uterine rupture, then you can't get the baby out quick enough. But on the other hand, it's only going to happen 1 in 500 times, so 499 times you can do it safely. And you know when you're having a home birth that you are in a place where they're committed to having a natural labor, and where you go in not thinking that you're going to have all these other things happen to you, like an epidural, and they don't have to take responsibility for what happens after the epidural. Does that make sense? I ramble a little bit.
No,
So
you're good. I want to ask you to, so how can a mother go to the hospital and have a successful VBAC? What could she do in that case?
Well, the first and most important thing is to go in and labor as opposed to being induced. There is a movement in the medical profession to start inducing people more. And I don't think that doctors and individuals understand the importance of that timing, that when you go into labor, there's something kind of, well, natural and magical about the fact that you're in labor, and that's when the baby has said it wants to be born and your body's ready. And so you don't want to ever be talked into being induced. It's okay to go past your due date. It's okay to be monitored for baby's well-being. But just understand that the longer you wait, the more the hospital starts, you know, starting to put pressure on you to change your mind about what you're doing. And so the important thing is to just go in spontaneous labor and to make sure you've got the support systems and to make sure you trust everybody who's in the system. And the number one issue with that is you have to make sure that the person who is going to back up your doctor who's doing the VBAC has to have the same philosophy. And that's where a lot of problems happen, because you walk in and your doc was a big fan, and then all of a sudden you're confronted by someone else. And that happened to me. I basically tried to be available for all my patients all of the time. And one of my patients walked in labor. She had had 2 previous C-sections, then she'd had a vaginal birth, a VBAC with me. And she walked in labor, and I think she was like 6 centimeters, and they couldn't reach me because I had turned my phone off when I went to a movie and I forgot to turn it back on. And the doc who was on call threatened to come over and do a C-section on her, even though she was in labor and moving along and the baby looked great. And luckily, I realized my phone had been turned off. I got the messages, I came up. But she was in tears because this doctor, my partner, was saying, you have to have another C-section. So it's super important that you essentially maybe go to a facility that has midwives that can do VBACs, because then they're going to manage your labor, and then they're going to ask that their backup physicians are going to be more pro-VBAC than usual. And I do know that there's hospitals where midwives are allowed to do VBACs, and that would be a good option if you want to be in the hospital.
That's interesting what you said about induction, because I called all 3 of our local hospitals today, and I just asked them, I kind of made up a story on the phone, but I was like, okay, well, I just found out I'm pregnant. I'm not. But I'm wanting a VBAC. Do you do VBACs? And McKay said yes, but they told me, they said, it is up to your doctor, but you know, when your doctor decides that is a good day for him, they'll schedule your induction and you'll come in and have your baby, and then you'll have the coverage for the anesthesiologist here. And I'm like, wait a minute, you're telling me that I need to schedule my induction for my VBAC? And they said yes. And I was like, well, I kind of heard that maybe that could be a little more dangerous to have an induction with your VBAC history. And they're like, oh, well, most of our doctors prefer to do it that way. Oh,
Did you record this?
It was an interesting conversation, but that is their, you know, their MO. But is it the safest and the best thing for you and your baby? Probably not.
So Pam, tell us some of the local hospitals' policies and the numbers and things that you found out.
Okay. Well, according to my phone calls today, all 3 of our local hospitals do VBAC, depending on your doctor and what your doctor says. And some were, so when I say the 3 hospitals, I'm talking McKay, Ogden Regional, and Davis. So they, besides the phone call with, well, McKay today, let's see, oh, I did want to mention McKay has laborists, who are there and kind of act as a go-between. Yes, so a lot of hospitals do not do VBAC because the physician doesn't want to be there the whole time you're in labor because, you know,
They have a ton of patients.
because they have a ton of patients, but not a lot of patients. So the laborist is there, and they're there for your labor, and then they call the doctor in when you're getting close, which is always really interesting to me, that women go to the hospital because that's where the doctors and the security is, but there's not a doctor there most of the time. So McKay has solved that problem by hiring laborists. She kind of rambled for a minute, and she talked about making sure that the laborists could be the coverage, and sometimes they don't, or not always. It doesn't always work out. So she said between 5 p.m. and 7 a.m. the laborist is there. So the tricky hours, I guess, are between 5 a.m. and 9 p.m. whenever the doctor comes in or whenever they arrive for the day. So yeah, that was an interesting conversation. Ogden Regional also said that yeah, they do VBAC according to whether the doctors requested or not. And Davis said the same thing. It depends on the physician. You must be monitored, but they did say that was pretty much the intervention that they insisted on.
Induction?
No,
Monitoring.
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 Sorry, I'm
Yes.
still on the induction thing.
Yes. So I guess here is where I say you have to know your doctor. And studies after studies on VBAC have shown that the biggest indication of whether you're going to have a VBAC or not is on how supportive your doctor is. That's it. Whether they truly and really support you or not is the deciding factor. And it is really important if you have a CNM, a midwife who works with OBs, that you know maybe the midwife's supportive and that's who you see every visit. Are her backups really and truly supportive? And I would highly suggest to have an appointment with them, to have them know you, to know your face, and to say, yes, I am committed to this VBAC, or, you know, so that they understand the importance of it to you. And in the backup OBs, I have stood in a labor room with a mom with prior cesareans who was coerced into a repeat cesarean because her doctor was unavailable, and it was the backup OB came in. And it was a Saturday night. She didn't want to be there, and she was not supportive of that birth at all. And it was probably the worst experience I have witnessed in a hospital setting. And it absolutely was abusive and coercive. And so you have to know those backup OBs and that they are supportive as your primary physician, which hopefully you have interviewed and have come to an understanding of what your options are, and found somebody who's supportive. We do have options in this area. They're hard to find, and the pickings are getting slimmer, but every once in a while you will find somebody who's being supportive. But what may be a great OB for one woman won't be for another. So luckily we also have some awesome home birth midwives in the area who do.
For a while, huh?
So I want to switch gears just a little bit, and I want to talk to Chris and ask her, because I think the big thing is to have support, and sometimes the husbands are the most hesitant. So what can we say to the husbands to help them be more assured that their wives will be okay in attempting a VBAC?
Well, I don't think it's just for VBACs. I think all husbands need to kind of be encouraged to support their wives in their choices, whether they're having a VBAC or a baby at all. So getting the education again, so, you know, going to classes and learning what the body does during labor, knowing what they can do to give her comfort measures. That's all part of it, but listening to her and knowing that this is something that she knows that she's capable of and that is something that she wants to do. I think it's really important to trust the wife. The man isn't going to be going through it. He's going to be providing all the support he can, and that's a really important role too. But one of the things that they do have to do, they do have to understand and what the body's doing and be supporting it. I don't talk well when I have a microphone in front of me. I'm sorry, you guys. I back off.
You're awesome.
Anyway, I just think it's really, you know, it's a woman's choice, and we're all there to support her choices. There's times when people walk in and come to me and they want a certain birth, and I'm uncomfortable too, but I have to be willing to trust that the woman knows what she can do too. So I think it's just really important, the education. Go ahead.
I think one of the issues that's important for fathers to know is that the VBAC is safer for the mother than the C-section. And so by her choosing that, she's actually choosing something that is lower risk for her. Now it carries this small risk to the baby, but then labor does the same thing. And so it's kind of, if a mother is fearful that she's going to end up with a C-section and then it means something, that she's afraid of that, you have to deal with the fears, but you also have to say there's a reason why she's choosing to want to have this baby vaginally. And so that's a good thing to listen to and allow your wife to talk about what's going on and what her fears are and how you can support her and what is she actually afraid of. Because I always encourage mothers to use their intuition. They haven't, you know, women have this power to sometimes know what's the right thing to do and the wrong thing, and they can't exactly verbalize what they're afraid of, but it's important to recognize it. And so if they want to have this feedback, then there's probably a strong reason that they want to do it that way.
Thank you. So I want to ask you, Dr. Zelenkov, as a doctor, or, you know, how do the hospital policies affect doctors who want to support and offer this to mothers?
Oh, you're bringing up my biggest problem is that I've been trying to practice in a community that, I mean, northern Utah is not super favorable for VBACs in hospitals. I mean, no matter what they say, there are, you know, they're calling it the doctor's prerogative regarding the VBAC, and the problem is that it's not the doctor's prerogative, it's the family's prerogative as to what they want and what kind of support they need. And so, unfortunately, my malpractice insurance, for example, would not cover me if I did a VBAC on somebody that had 2 previous scars or more. They theoretically said, we're not going to cover you. I went and talked to the malpractice lawyer who would defend me, and he says, well, you can always use your best judgment, and if nothing bad happens, then we'll support you. But it puts a lot of pressure on me to make sure that I don't ever, you know, have a uterine rupture, because they're going to say, well, geez, you should have known. And then the other issue is that the hospital has put a lot of pressure on doctors who are trying to practice in their patient's best interest, but not in the hospital's best interest. And so that's the problem that I came up with a lot, is that, you know, for example, I had a patient who had 3 previous C-sections, and she came in spontaneous labor, and, you know, she was just moving so quickly. You know, everything was doing great, but on the one hand, I had the perinatologist on the phone telling me, oh, but she's having these little variables. This means that she's going to rupture. And I go, no, she's going from 6 to 8 to 10, and she's just zooming through labor. And And I will tell you that, you know, I got a black mark for the fact that she delivered vaginally and didn't have anything bad happen to her, but I got the reputation of challenging the authorities. And that's a big problem for doctors who kind of push the envelope for patients who want to have somebody help them. And so, because the hospitals, no matter how they say it, and the doctors, no matter how they say it, it's all about risk management. And so, you know, they don't want that 1 in 500 thing to happen or that 1 in 1,000 thing to happen. And they don't look at births as being natural. They look at them as something that needs to be managed. And it is true that they have to manage it, because when you go into the hospital and they break your bag of water, there's the risk that you could have uterine, you could have cord compression. Well, then you have to have a doctor who does amnioinfusion and puts fluid in and helps to prevent the cord compression and monitors the strength of the contractions, because we did something, you're now having a problem with it, we need to try to prevent it from causing the fetal distress that then is going to cause the C-section. And so, you know, anytime somebody has had a C-section and they were told that the baby is at risk for stress, if your baby comes out and has great AFRs and looks great, well, somebody made a misdiagnosis. And yet patients never, ever sue for that situation. They sue, they sue if something bad happens to the baby, but not if something bad happens to the mom. And that's the problem, is that women don't stand up for their rights.
We've tried. I have seen mothers with permanent damage to organs, surgery after surgery, and they go in and they try to find a malpractice lawyer to say, hey, this has happened because that happened, and it's not enough. It's not enough. The lawyers will not go to court on it because there's not enough payback for them, and they don't see it as a winnable case. It's because it's not as if something happened to the baby in a life-threatening way. It was the mother who sustained the injury, and so we've looked at cases like that. We've looked at several cases like that over the years, and have been unable to bring it to court. And not that we haven't tried, we have, and
So what are a mother's rights? What are her options? What can she do if she wants to have a VBAC? What are her choices? What are her best options? What's available to her?
you asking me?
Dr. Zelenkov.
Okay.
Yeah.
Well, the number one thing is to know that there are people who will support you if they feel that you're a good risk. You know, there have been patients who have gone to the University of Utah where Dr. Silver practices, and he's very